We are exploring insights from Dr. G.S. Raju's YouTube.
It's a fantastic resource.
Yeah.
Really, it's a visual masterclass in how to look at the human body from the inside out.
And usually on these deep dives, we're looking outward.
Yeah.
We're talking space exploration or technology.
Mm-hmm.
But today, I want to flip that. We are going inward, literally. We are taking a journey into inner space.
A landscape that's just as complex and, well, frankly, just as alien as anything you might find on another planet.
That's what hooked me. We're not just looking at diagrams. We're exploring a real terrain. It has its own geography, its own weather pattern.
And its own warning signs, definitely.
We're looking through the lens of an endoscope, venturing down into the human stomach.
Mm.
But the perspective we're taking is key here. We aren't really looking at this as a doctor.
No, the source is really aimed at the co-pilot, so to speak.
Exactly. We're seeing this through the eyes of the endoscopy nurse or the technician who's standing right there.
Which is such a critical distinction. Because look, if you're the doctor, you're the pilot, you're driving the scope.
Right.
But Dr. Raju's point is that the nurse or tech isn't just a passenger. They have to be active. They have to anticipate.
It's called anticipated recognition, right? This idea that you should know the landscape so well, you know what tool is needed before the doctor even asks.
Precisely. It's all about recognizing normal. So instantly, that abnormal just screams at you from the screen.
So let's start the tour. We're past the esophagus. We're entering the stomach. Now, I assumed you'd just drive straight in, but the source describes a very specific move right at the start. You have to turn the handle left. Why?
It all comes down to gravity and architecture. The stomach isn't just a sac. It has a specific shape.
Okay.
So when the patient is lying on their side, usually the left side gravity is going to pull everything down. By turning left, you drop the scope's tip right into the fundus.
The fundus.
Think of like the basement. It's the lowest point in that position. And, just like a basement, that's where everything pools.
The pooling station. I like that. So before we even look at the walls, we're looking at a pool of liquid.
And that pool is your first diagnostic test. Before you even suction it out, you have to analyze it. It's almost forensic. The color tells a story.
Okay, let's run through the color palette. If I see clear liquid, what's that?
That's perfect. That's just normal gastric acid.
And then there's light yellow. Now, yellow feels like a warning to me, but the source says it's okay.
It is. It's within the normal range. That yellow is bile. Sometimes a little bit of bile washes back up from the small intestine.
Yeah.
A little bit is no big deal.
So clear is good, light yellow is fine. But then we get to the real warning colors, dark bile.
That's your first major check engine light. If you see thick, dark green or brown fluid, you've got a problem. And the problem isn't in the stomach, it's downstream.
It's a traffic jam.
Exactly.
Oh.
It means there's a blockage further down the line, maybe in the duodenum. The bile can't get through, so it's backing up.
Wow. So just from the liquid, you're already thinking about the intestines. Now we have to talk about blood. And it's not as simple as just seeing red. The source makes this fascinating distinction between fresh blood and coffee grounds.
Coffee grounds is one of those medical terms that is just incredibly vivid.
And pretty disgusting, but it sticks with you.
It does. And the chemistry is the key. If you see bright red blood, that's active bleeding. It's happening right now.
Okay.
But if that blood sits in the stomach for a while, it's sitting in hydrochloric acid.
The acid starts to digest the blood itself.
It does. It oxidizes the iron in the hemoglobin. That chemical reaction turns the blood from red to black and gives it that grainy texture.
So it gives you a timeline. It tells you the bleeding happened hours ago. Maybe it's even stopped.
Exactly. It changes the urgency. Fresh red is a crisis. Coffee grounds are an investigation.
Speaking of crises, let's talk about finding solids, finding food.
The dreaded food bazaar.
It sounds like something out of a fantasy novel, but it's a huge medical hazard. Why is finding, say, last night's dinner such a big deal?
Because it's a massive safety issue. I mean, first, you have to remember, these patients are supposed to be fasting for hours.
Right. The stomach should be empty.
So if it's not, that tells you the stomach isn't working right. That could be gastroparesis or even a blockage like pancreatic cancer.
So the stomach itself is broken, but why is the procedure dangerous?
It's all about the airway, the lungs. When a patient is sedated, their gag reflex is suppressed. If you're poking around a stomach full of food, you could easily make them vomit.
And if they vomit while they're sedated?
It doesn't come out. It goes down, straight into the lungs. That's aspiration pneumonia.
Yeah.
And it is catastrophic. It can be fatal.
That explains the protocol in the source. It's not work around it. It's stop, get out.
Immediately abort, You pull the scope, rake the patient up. The only way you'd proceed is if you intubate them first to physically seal off the airway. You just don't gamble with it.
Okay, so that really raises the stakes. But let's say the pool is clear, we've suctioned it out. Now we can finally look at the landscape itself, the stomach walls.
The wallpaper, yeah.
So what does a healthy stomach look like?
Well, you might think it would be smooth, but a healthy stomach is actually pretty rugged. It had these long ridges and valleys. They're called rugal folds.
Like an accordion?
That is a perfect analogy. Those folds allow it to stretch when you eat. So you should see these thick, healthy ridges.
But the source shows us what happens when they vanish. This thing called gastric atrophy.
Right. The lining of the stomach thins out. The folds just disappear. The walls become totally smooth, almost bald.
And there was this detail that just blew my mind. The source said if you saw a picture of it, you'd swear you were looking at the colon.
A classic mix-up for a novice. See, in a healthy stomach, the lining is too thick to see what's underneath. But with atrophy, it's like tissue paper. You can see all the blood vessels underneath.
And that vascular pattern looks just like the colon.
Exactly. So if you're in the stomach, but it looks like the colon, you have atrophy. And that's not just a cosmetic thing.
No, it connects to a vitamin deficiency, right?
Pernicious anemia. The cells in those folds are what make intrinsic factor, which you need to absorb vitamin B12. No folds, no B12 absorption.
So you're looking at a bald stomach, but the patient's real problem is anemia.
It's all connected. The stomach is telling you about the blood.
There was another texture I found really unsettling. We've had bald, now we've got reptilian, the snake skin look.
Ah, yes. A very distinctive mosaic pattern, like little scales.
And this weirdly points to the liver.
It does. This is portal hypertensive gastropathy.
Break that down for me. A liver problem causes snake skin stomach. How?
It's a plumbing problem. Think of the liver as scarred and hard, maybe from cirrhosis. Blood can't get through it easily, so the pressure builds up backwards.
Like a dam.
A dam, exactly. That high pressure backs up all the way into the veins of the stomach, and the lining gets swollen with fluid, edema. That swelling creates the scaly pattern.
So a tech sees snake skin, and they should be thinking, this patient might have cirrhosis.
That's the anticipated recognition right there.
Okay, let's move from textures to actual damage, starting small with erosions.
Erosions are like surface scratches. They don't go deep. Visually, they're just flat red streaks, maybe with a yellow dot in the middle.
And these are often the lifestyle injuries, yeah.
Very often. Heavy drinking is a big one. But also NSAIDs, aspirin, ibuprofen, those common painkillers.
Right.
They strip away the stomach's protective mucus layer, and then the acid just starts nibbling away at the lining.
But if you keep nibbling, you get past a scratch and you dig a hole, you get an ulcer, the crater.
An ulcer is a true excavation, a pothole in the lining.
And this brings us to the scariest game of spot the difference. You see a crater. Is it a benign ulcer or is it cancer? Because they can look really similar.
They can be deceptive, even for experts. But there are clues. A benign ulcer usually looks tidy. The edges are smooth and sloping.
And cancer.
Cancer is messy, it's chaotic. The folds around it might look clubbed or chopped off. The edges of the crater are irregular. But there's a test Dr. Raju mentions that I love. It uses the air pump.
The rigidity test.
Exactly. A normal stomach is like a balloon, it stretches. If you pump in air, a benign ulcer's walls will distend with the rest of the stomach.
But cancer doesn't stretch.
Cancer tissue is hard, it freezes the wall. So you pump in air, the stomach expands, but that one area around the crater stays flat and rigid like a board. That's a huge red flag.
That's incredible. But even with all these clues, the source has a golden rule.
The rule is, trust nothing. You cannot diagnose cancer with your eyes. Every single gastric ulcer must be biopsied.
And not just one little piece.
No, because cancer can be catchy. You have to take a minimum of 6 to 8 biopsies. From the edges, from the base, you have to be absolutely thorough.
And you also check for H. pylori bacteria.
Always. It's a major cause of ulcers. Treat the bacteria, you can often cure the ulcer.
I want to get to what is, I think, the best visual name in this whole deep dive. We've had coffee grounds, snakeskin,
No.
the watermelon stomach.
It is impossible to forget once you've seen it.
Describe it.
So this is usually in the antrum, the bottom part of the stomach. You see these bright red streaks radiating out from the center. It looks exactly like the stripes on a watermelon.
And these stripes are actually blood vessels.
They are. The medical term is gastric antral vascular ectasia. They're dilated, fragile vessels right at the surface, and they ooze blood.
So a patient comes in anemic and tired, and inside they have a watermelon that's slowly bleeding.
That's exactly it.
Okay, let's go back up to the top, to the fundus. We talked about it being a pool, but there's another check that happens up there. The source talks about a hug.
And the hug of the scope, yeah. This is for checking for a hiatal hernia.
How does that work?
So when you do that U-turn to look back at the scope entering the stomach, the tissue should wrap tightly around it, like a tight collar, a hug.
And if there's a gap?
If you see a space, if the tissue is loose, that's a hiatal hernia. It means part of the stomach has slipped up through the diaphragm into the chest. It's a mechanical failure.
And while you're up there's another scary finding. Blobs of vessels.
Varices. This is the extreme version of that high pressure from the liver we talked about. These are veins that have ballooned out into what look like clusters of grapes.
And they can burst.
They are incredibly dangerous. If one ruptures, it's a massive, life-threatening hemorrhage. Spotting those is absolutely critical.
Wow, it just keeps coming back to the liver, doesn't it? The stomach is just taking the punishment.
It really is a connected system.
Before we wrap up, there was one more finding that's just so ironic. Polyps. Specifically, fundic gland polyps.
Little smooth bumps on the lining.
And the cause is medication.
Specifically, proton pump inhibitors, PPIs. Things like omeprazole, Nexium.
That is wild. Millions of people take these drugs to protect their stomach, and the drug itself changes the anatomy.
It's a classic feedback loop. The drug suppresses acid, so the stomach senses the lack of acid and tries to compensate by growing more of the cells that make it.
Are they dangerous?
The good news is, no. The source is clear. They're typically benign. They rarely become cancer. But it's a striking reminder that every pill we take leaves a footprint.
So we've toured the whole organ. We've seen coffee grounds, snakeskin walls, watermelon stripes, the craters of cancer. When you step back, what's the big takeaway from this anticipated recognition model?
For me, it elevates the role of the observer. It proves that medicine isn't just about the doctor's hands. It's about the entire team's eyes.
It's about being a decoder.
Exactly. The stomach is telling you a story about the liver, the blood, the patient's habits. But it's written in a code of colors and textures. If you don't know that no folds means check B12, you're just looking at pink slime.
You have to speak the language.
You have to speak the language to save the patient.
And for me, the thought that's going to stick with me is about fragility. That food bizarre.
Yeah.
The idea that our whole digestive system can just stop. That a leftover meal can turn a routine procedure into a life or death fight for the airway. It just highlights how delicate this internal machinery really is.
We think of the stomach as this iron furnace, but it's really a sensitive instrument. And when that rhythm breaks, the consequences are immediate and severe.
Well, this has been an incredible journey. I will definitely never look at a watermelon or coffee grounds the same way again.
Nor should you.
Thank you for listening to this deep dive into Dr. G.S. Raju's YouTube.
Stay curious, everyone.